Hi, Shannon. Thank you so much for joining me today.
Hi, Alex. Thanks for the invitation.
Yeah, I'm really excited to finally be able to interview the Lerner Chair. It's very exciting. So to start off, can you just please introduce yourself to everybody? Tell us a little bit about your educational and personal background.
Sure. I'm Shannon Monnat. As Alex mentioned, I'm the Lerner Chair in Public Health Promotion and Population Health, but I also direct the Center for Policy Research here in the Maxwell School at SU, and I'm a professor in the Department of Sociology. My educational background is, well, I'll just say first that I'm from upstate New York, a small town called Lowville, which is about an hour and a half north of Syracuse. So that's where I went to school, K through 12. And then after I graduated from high school, I started my college career at a community college in Watertown, New York, named Jefferson Community College. And there I took a bunch of social science and humanities types of courses. Very interested in English at the time. So I took a lot of English courses, I took a lot of psychology classes, and I took my first sociology course when I was at community college. I believe it was a course on sociology of families, marriage and family, which was really interesting. And I thought, this is what I've been missing my whole life. Like, this just fascinates me. I became really interested in social behavior and relationships and inequality. I ended up taking another social course called social psychology while I was there. And then, after I finished my associate's degree, I transferred to SUNY Oswego, which is also here in New York State, Central New York. And I got my bachelor's degree in sociology at SUNY Oswego. Following that, I immediately went to graduate school, also at a New York State school. I went to SUNY Albany, where I got my PhD in sociology. So I like to say I am 100% New York State public school educated.
Love that. That's awesome. Good promo for them. So tell us a little more about your research. What is it that you have expertise in, and what are the type of questions that you're asking?
So I consider myself to be a social demographer and population health scholar. And what that means is I'm interested in big picture issues about population health. In particular, I have an interest in geographic disparities in health and mortality. I'm interested in trying to figure out what are the characteristics of places that explain why mortality rates are higher or different health outcomes are worse in certain parts of the United States than in other parts. If we narrow that down to be a little bit more specific, I can talk about a couple of projects if that would be useful right now, or if you want to wait.
Yeah, sure. Yeah.
So in terms of some specific projects, for several years, I spent quite a bit of time trying to understand why drug overdose rates were higher in some parts of the US than others. I was interested in the role of, for example, county level economic conditions and family structure characteristics on where drug induced mortality rates were high versus low. In more recent years, I've continued my interest in drug overdose, but I've been trying to understand geographically different experiences in relation to the COVID-19 pandemic. So where were COVID-19 mortality rates high, and why were they high in those places? Why were vaccination rates higher or lower in some parts of the US than others? And in a couple of currently funded studies from the National Institutes of Health, I'm part of research teams that are trying to understand the combined roles of state policies across a wide variety of domains and county economic conditions across a wide variety of different domains, and how those factors interact to help us understand trends in mortality, especially among US working age adults, and also geographic disparities in mortalities in this group.
So what piqued your interest both in looking at drug overdose and mortality trends, and now, I mean, COVID maybe is slightly more obvious, but also not. So what kind of drew your interest to these specific areas and looking at these types of trends?
I think this is a really great question, but I'll also say it's somewhat of an accident, my interest in these outcomes. I think I've always been interested in place level factors and their role in different outcomes. So how does where we live influence our access to a wide variety of opportunities and resources? How does it influence our life chances? And I think part of that comes from being from a rural town in upstate New York, where I saw a lot of people struggling. I saw a lot of people who didn't necessarily have the same opportunities in life, the same opportunities to go to college, or the same opportunities to live healthy lives as people in maybe some better resourced parts of the country. And so, as a sociologist, I just became interested in what explains those differences in opportunities. In terms of drugs, this was a complete accident. I was at a conference that was organized by the Robert Wood Johnson Foundation, and it was for what they called underrepresented scholars in population health. And I was considered to be underrepresented because I'm first generation college student. I was the first student in my family to go to college. So that was one of the markers that they were using. And I was at this conference. And as you often do at these conferences, you meet other people and you talk to them about their research interests. So this person who I met, Curry Rigg, met him at a bar, and we were just, sitting there chatting about our research. And he told me that he was doing research on prescription opioid misuse among Black people in urban Florida. And I thought, well, this is really interesting. Like, what is this all about? This was, gosh, we're talking about over 10 years now, maybe like 12 years now. So he's telling me about this research and I'm finding it fascinating. And I'm asking him all these questions about prescription opioid misuse, like what is it and why would people do it? And, at some point I said, well, way back in the day when I was in graduate school, I was sort of interested in methamphetamine and why methamphetamine rates were so high in rural America. And it had nothing to do with my dissertation, but I read this article about it and I became fascinated and I thought about changing my dissertation topic for like 3.5 minutes. And then I decided, no, I just like really wanted to finish this PhD. So I had to get this darn thing done. But I would come back someday to methamphetamine because it fascinated me. But I never did. And then I'm talking to him about prescription opioids. And I said, I'm still, really interested in rural drug use. So have you ever written a paper about rural urban differences in prescription opioid misuse? And he's like, no, I'm focused my time on urban environments and I'm a qualitative scholar. So I collect data and interview people. And I was like, all right, we should collaborate, right? Like we should write a paper together. And I wanted to use secondary data. I didn't know any data existed. So, we came back from our conferences. I did some hunting around. I found this national survey on drug use and health. And I saw that they had metro status indicators and they had indicators for different types of drug use. So we were going to write one paper, a paper on rural urban differences in prescription opioid misuse. And that was going to be our collaboration. And I was going to go back to my research that I was doing, which was on something completely different. And that would be that. But I became fascinated. So just, like really invested in this topic. I became invested time-wise because it takes a long time to learn the data. These are new data that I hadn't used before. So I had to review the code book, get to know the different variables, figure out how they operate. So we ended up writing like 5 or 6 or 7 more papers.
Wow.
On differences in drug use across different social groups, across different geographic groups. And of course, around that time is when this topic really started to blow up.
Yeah.
So the timing was very odd because there wasn't much chatter about it like when we first started. And then it just in the media, because the mortality rates were rising so much, the media and politicians became increasingly concerned, first about prescription opioid misuse and then heroin. And then when, Case and Deaton's midlife mortality study came out, it blew up even more. And, so the timing was very odd. But I started doing this research in an era with increased policy attention to this topic. And then I felt like I really couldn't leave the area.
Sure. Yeah.
Of course I cared about it, but also there were just all these unanswered questions that people had about it. And I felt like as a demographer and someone who is sort of interested in the big picture, I really wanted to better understand what was driving these geographic trends. There was a lot of discussion about like, it's all supply. It's really all supply, right? Um, and so the more I dug into it, the more I thought, well, there's something else going on here. Supply may have been, sort of fuel, but underneath that, there was this underlying vulnerability and demand for these drugs that would numb not only physical pain, but psychological pain.
Yeah.
And so it was this perfect storm of this underlying demand, call it despair or distress or, psychosocial ill-being or physical pain or whatever. There was that, which was at higher prevalence in certain geographic areas in the US than others. And then there was this really highly addictive and deadly drug that came along that was not super expensive, that people could get easily, and that once people developed a habit for it, it was really difficult to kick. And those two things came together to really ignite this population health crisis that we were dealing with drug overdoses.
Yeah, and do you maybe credit some of this work too to your deep interest in the role that policy plays in a lot of these things, like seeing the way in which policies are implemented, and the impact that they have on access and those types of things, and that rural urban divide, and then also seeing that like very clearly play out during the COVID-19 pandemic.
Yeah, and policies are another area where I've come full circle from graduate school. So, that didn't occur to me at all until the question you just asked me. Because at first when you were asking that question, I thought, well, I hadn't really done much work with policy until the last few years, really with COVID-19 related topics. But it turns out that's not true. My dissertation was about racial differences in welfare sanctioning under TANF. So different states have different policies for when to remove a person or reduce their benefits because they violated some requirement of TANF, Temporary Assistance for Needy Families program. So even though that my dissertation had nothing to do with health, at least directly, my primary exposure was a policy variable. I was looking at policy variation across different states. So this is like the first stuff that I ever did was policy stuff. And then, I sort of moved away from looking at state policies for a while. And when I was a faculty member at UNLV, I collaborated with a kinesiologist who was really interested in physical activity and physical education policies in schools. And so we were looking at variation in those types of policies, like whether schools, whether states require schools to offer a certain number of PE hours per week, whether you can opt out of PE, all of those things. And we were looking at the relationship between that policy variation and the amount of time that kids actually spend in PE and the amount of moderate to vigorous physical activity they get. So it was another area where I was looking at policies on a completely different outcome. And then when I came to SU, I had the really remarkable benefit of becoming close with Jennifer Montes, who is, one of my closest friends and collaborators, and she has a deep interest in state policies and has really recognized for a very long time, earlier than pretty much everybody else, that states were increasingly becoming the battleground for policies, and that those policies were becoming increasingly important for helping us understand diverging health profiles across the country and diverging mortality profiles. So, she, for several years, published studies on how states with certain types of policy environments had much higher mortality rates than states with other types of policy environments, and that those states were increasingly diverging in their policy environments, and that was really tightly correlated to the divergence in mortality. So, having the opportunity to work with her over the last several years has just deepened my interest in the roles of states and, really helped me recognize that multiple place level factors work simultaneously to affect our health. So it's not just a particular state policy. It's not even just the combination of state policies, but it's also how these policies interact with our local economic environments, our local physical infrastructure. Policies can drive those things. You could have, a state that has, very strong minimum wage, for example, might have better economic environments too. But in addition to driving those lower geographic level factors, state policies and those factors interact so that, being in a poor county in a more conservative state might be more harmful than being in a poor county in a more liberal state for your health, for example.
Yeah. That's just fascinating. And my next question was going to be like, what is one key takeaway that you have like from your research that you want people to know? But I mean, I kind of think that's it. I mean, at least part of it, right, is the complexities. And I've had other affiliates say this too, like that the complexities of understanding health, like it's never ending. Like you learn one thing or one factor, and all that does is create like more questions. I mean, do you have anything you'd like to add to that in terms of the key takeaway? I don't want to.
No, I think that's right on. I think a big aha moment for me was a few years ago. I was a member of a consensus committee for the National Academy of Sciences. And the way these committees work is they bring together people with expertise on a particular topic from across the country, and the committee members meet several times and, try to understand the factors that are driving some outcome. And in this particular case, we were trying to understand rising midlife mortality and socioeconomic disparities in that rising mortality. And so the first thing that we had to do was understand the causes of death that were driving the increasing mortality rates and declining life expectancy among working age adults. And by working age, I mean people ages 25 to 64. That was the group that we were focusing on. And that's an important group because in the US, that's a group that has contributed most to the US's stagnation in life expectancy increases. So for several decades, life expectancy was increasing in the US right along with our peer countries, our other high income countries. And then, life expectancy started to like decline, or started to improve less in the US than in other countries. And then life expectancy just started to like even out in the US and not increase anymore. And then it actually started to decline. And the driving factors behind not only the US's divergence from our peer countries, but also its stagnation and decline has been that working age group. Okay, so that's sort of setting up the problem. So this committee had to start by understanding what are the causes of death driving this. And we nailed down 4 causes of death. Drug overdoses, which might seem obvious to you, Alex, given your expertise in this area, because drug overdose rates have just surged in the US in that group over the past couple of decades. In addition to that, suicides, while not increasing as much as drug overdoses, had been increasing in working age adults, and alcohol-related diseases had been increasing. That there was this 4th cause, cardiometabolic diseases, which are a combination of ischemic heart disease, metabolic diseases like diabetes, obesity-related diseases, etc. And some of those causes of death, for some of those causes of death, the mortality rates have been increasing in working age adults, like diabetes related mortality, for example, or metabolic diseases. And then for like the big one, the heart disease, it's not so much that it's been increasing, but its long-term progress had stalled. So for a lot of years, mortality from heart disease had been in decline, but that stalled like starting in the 2010s. Okay, so we identified these 4 causes of death. And the aha moment for me was that no matter what factor we tried to use to explain what was going on with these 4 causes of death, we kept coming back to there is no single factor. Because it's like, well, maybe it's poverty. No, it can't be that. Maybe it's that we have increasing racial ethnic disparities. No, that's true, but it's not that. Maybe it's despair, and there's just been like this increase in despair over the past several years, and that's what explains all 4 of these causes of death. Well, no, it's not that. Well, maybe it's policies and policy environments. Well, no, that can't explain all of it. So the aha moment for me is that given the number of causes of death that have increased, and given that there have been increasing disparities across education, across rural urban status in all of these different causes of death, there can't be a single explanation. That there are multiple factors at multiple levels, federal, state, local, individual, and across multiple dimensions. So, economic dimensions, policy dimensions, environmental dimensions, dimensions that have to do with our, corporations putting a bunch of junk in our food and deregulation of those corporations over time. All of these factors have interacted to create conditions that are more health harming now than they were, say, a couple of decades ago.
Well, that's a bummer. And I think
Indeed,
also like a
this is
rallying cry, right? Like it's that there's just so much to uncover and undo and to change, and like that it's such an important, there's
yeah,
important things to be looking into, even if you don't have like the answer, right?
right.
Like
But there
answering.
is hope, right? Like I don't want to leave the conversation in this sort of like,
No.
pessimistic, we've got all these problems, we can't do anything about it. I take hope from the fact that the US has solved difficult problems before, and it's implemented policies that have improved health and reduced mortality. And I can just give you a couple of examples, right? Like seatbelt laws.
Mhm.
Seatbelt laws led to a dramatic decline in motor vehicle fatalities. It's a very, on the surface, seemingly simple thing to do. There was a lot of pushback, of course, as there always is when you try to impose some new thing onto a population. There was political divergence over this thing, but cars now all have seatbelts in
And if you
them.
don't buckle
And
them, your car gets mad at you.
you don't, what is it? If you don't click it, you get a ticket.
Yeah, that too. Yeah, yeah.
And cars that now have these signals in them that keep
Yeah.
beeping if you don't buckle your seatbelt, right? So like there are interventions at a kind of big picture macro level that have proven to be effective in reducing mortality. That's one. I'll give you one more example. Smoking rates used to be very high in this country, and there's a very strong connection between cigarette smoking and lung cancer. Like undeniably strong connection. So, not shockingly, places that had higher rates of cigarette smoking had higher rates of lung cancer. Okay. So, states that impose higher taxes on cigarettes, higher tobacco taxes, have seen more dramatic declines in smoking prevalence and have seen dramatic declines in lung cancer mortality. So there are things that can be done at the federal level and the state level and even the local level to improve the conditions in which we live to help create happier and healthier lives.
Yeah, and some of that is nudging behaviors too, which I'll say for Len Lopo to when I do his interview to dive deeper into for us on that. But to wrap up this interview, I always ask this fun question at the end, which is, what is a book or movie, podcast, something that you have been interacting with recently that you just have loved? And it can't be your book. We will promote that though. Just to understand
Yes,
Shannon a
well,
little
my
bit.
book is just very fascinating. I love to read. I read every night before I go to bed, assuming that my head doesn't hit the pillow and I have to fall asleep immediately. But I try to read every night before I go to bed. And as much as I've read lately, I keep going back to like my very favorite book that I've ever read is The Grapes of Wrath by John Steinbeck. I think it's the best rural sociology book that has ever been written. And I've enjoyed a bunch of other books since that. I've increasingly gotten into sci-fi sorts of books. I very much like legal thrillers and, you know, John Grisham, Robert Dugoni sorts of things, but I keep going back to Grapes of Wrath. I also, in
Legal
terms of
thriller though, that seems like an oxymoron to me, but
legal thriller, yes, you know, like there just people get murdered
mm,
and then it's a whodunit. You have to figure out who did these things. And I really like the Grisham ones because a lot of the John Grisham ones like go back to some shady corporation that
mm,
did something naughty. And then, you know, the protagonist has to figure out what's going on and save the day.
yeah.
Um, I I recently became introduced to Suits, which was like
Oh,
big several years
yes.
ago, but I didn't watch it when it was on TV. And then it came to Netflix and
Mhm.
became really big. And so I've been binge watching Suits because I like these legal sorts
Yeah,
of shows. And I've become quite addicted to Harvey Specter and
I mean, how could you not?
Donna Paulson. It's just they're some of my favorite characters on TV.
Yeah, I love Louis Lip. He's probably my
Oh,
favorite.
Lewis,
I
yes,
love a
Lewis,
little unhinged
fantastic.
character. That's where I'm
He's
drawn to. But
and you know the character arc. He's developed over time, which is
yeah,
always really great to see.
yes, yes. Well, thank you so much for your time. This was lovely getting to learn more about your research and how you got here. So thank you so much.
Thanks, Alex.